Recently, the Society for Vascular Surgery decided to create an audio-video library of interviews with those who have contributed the most to vascular surgery. Dr. Jimmy Yao is our committee chairman. Dr. Roger Gregory, who's with us today, is on the committee, and we may be joined later by Peter Lawrence, another member of our committee. The idea is to learn from those who have provided the leadership in vascular surgery. I'm Norman M. Rich, and today I have the honor of interviewing the legendary surgeon from Toronto, Canada, Dr. K. Wayne Johnston, and it's a pleasure, having known you for at least 35 years, to be able to interview you today. A good place to start, Wayne, is to tell us a little bit about your youth.
My father was in the Second World War, a mechanic for airplanes, not overseas, but in Canada. And when he finished his service, he was given an opportunity to do engineering, which is what he did, and he practiced as an engineer for his life. My mother was a nurse. She only practiced briefly. I grew up in basically Toronto and have remained there ever since.
Did you have any physicians in your family?
There are no physicians in the family. My grandfather was a pharmacist in a small town, and I still remember how busy he was. You made money in those days from filling prescriptions and not from selling cosmetics or groceries, as happens now in our pharmacies. And I still remember him having to concoct the liquids and having to compact the pills in order to do this. So he was an influence, because I saw how hard he worked and how much he contributed to his small town.
So they were mentors for you in high school. Did you have anyone who fueled your interest in the biological sciences, or did you always have the engineering component?
I don't think I was ever actually very good at biology. There were too many mysteries, whereas physics and mathematics were pure sciences to me, and they were much easier for me to understand.
And that's why you've always maintained your engineering background interest.
It is. I'm not a legitimate engineer, but I have an interest in the background in the physical sciences as opposed to the physiological sciences, actually.
When you were looking toward higher education, did you have someone who was a mentor that steered you to where you went to medical school?
I think my mother saw me as a surgeon from when I was born. She had an obsession, I think, with surgeons from her nursing training, and I had to put that behind me, but finally decided to do medicine and indeed eventually surgery, and so that is what she wanted me to do, and I like to think I chose it, but it's hard to know.
One thing, even though we share the North American continent together, one thing that is a little bit different in our educational systems is the more postgraduate level, that type of system. Did you go directly into medical school from high school?
In those days, it was an option to go straight into medical school, and that's what I did. I went into pre-medicine and then straight into medical school. By sheer luck, I have no idea how I got into medical school. I didn't have an A average, but I managed to get into medical school and to slip through pre-meds and medicine.
Along the line, did you pick up any mentors?
I think probably my wife, who was a girlfriend at the time, was my major mentor and person who stimulated me to move from the back row of the class to the front row of the class, where I could learn a little more. And indeed, that was a success.
She was also a classmate.
She was a classmate, that's correct.
Same year, yeah, good. Well, along those lines, you are getting close to finishing medical school. You had to make some decisions. What went through your thought process at that time?
Everything except surgery. I think I enjoyed surgical. I think I enjoyed the surgical aspect of the curriculum the most. I was concerned that my mother's influence was perhaps talking me into something I didn't want to do, and I recall distinctly taking fits of work into other specialties. For example, I spent 2.5 weeks studying coma and left everything else slide, paid the penalty for it, and did that sort of thing throughout. Probably in terms of my medical school, the biggest influence that I had was from my summer work. I had the opportunity to be an extern in the cancer clinics of Ontario, one in a small town and then in Toronto at the Princess Margaret Hospital. It gave me an opportunity to do research and to actually do some clinical work at the same time. I think probably that combination is what stimulated me eventually to be an academic surgeon.
Right. So you did have to make a decision about what residency you were going to pursue.
Yes.
Tell us a little bit about that, please.
Well, Toronto was the most logical program, probably one of the better programs. I chose to stay there. The initial flurry of activity related to what I was going to do. I graduated well in our class. I was a silver medalist, so I think I was accepted fairly readily into the surgical program, and I had not embarrassed myself on my rotations, because in those days we were junior interns before we went into surgery. And I decided to go to the University of Toronto, and I didn't apply anywhere else. But at that time, the structure was to do a year of research first. I met with the chairman of the department at that time, a very austere individual, and he told me that I would do XX for research in my first year, and I pointed out that I had done 2 summers of solid research with real biologists, and that that's not what I wanted to do. He explained that indeed that's what everybody did in their first year of training, and he said, well, if you don't do this, where will you go? And I said, McGill. I had not applied to McGill, so that was the first time in my life I'd ever played a card I didn't have. But he said, fine, I didn't have to do research. I was the first person to plan to do research later in my career. And in fact, I was committed at that time to basically do a PhD in the middle of my surgical residency.
Were you bilingual at that point?
No.
Were you French speaking?
No, I was not bilingual at that point, nor am I now.
Yeah, right.
I almost didn't get into medical school, and one of the reasons my average was so low into medical school was because of French. I failed French at spring. They gave me a 51. A 51 meant they looked over something and gave it to you, because otherwise I would have been one subject short of university. So languages were not and are not my skill.
You finished your year of research. Along that line, did you have anybody that stimulated your further interest?
Well, I should say I did my research after my training,
Okay.
and I'd had 2 wonderful summers of doing research in medical school, and one of them taught me all about clinical science. And that is that you had to do things with a prospective audit, and that you had to have the right methods to do it. And that was one of the things that stimulated my interest in life table. Then I had the opportunity in a second summer to work in a laboratory at Princess Margaret Hospital next to a lab that was run by McCullough and Till, names that may not mean much to you, but if McCullough had lived long enough, he would have won the Nobel Prize for stem cells. And so we were in one lab, he and his colleague were in the other, and I was with Bob Bruce injecting blood from one mouse into another mouse that had been radiated. We noticed these little bumps would appear on the spleen, and in our lab we called them colony-forming cells. And in the other lab they recognized this was bone marrow.
Yeah.
And demonstrated, and then in Nature and published in Nature in the early 60s. So it was from that I developed an interest in doing research at a serious level. So I'd actually planned during my surgical training, when I was going to be a hepatobiliary surgeon, to actually do a PhD in pancreatic physiology. And then I caught wind of vascular, and that's when I made the switch. And after I finished my training, I only did 1 year of research, interestingly enough, but I developed an interest in vascular in mid-surgical training.
Again, was there any one person who really stimulated your interest in
I think what stimulated, no is the answer. I think what stimulated my career in the early 60s was the technical challenge, and the fact that in our environment, it was the cardiac surgeons who were doing the vascular surgery. They were getting busier with their hearts, and vascular was falling by the wayside and was not stressed. I saw a vacuum in an area with a great technical challenge, and that was too much. That's what swayed me into doing it.
Did you do what we would call a vascular fellowship?
Yes, with Ron Baird. In those days, it was very informal.
Right.
And I had the good fortune to work with Ron Baird and a fellow named Don Wilson, who went on to be chairman of our department, two very contrasting individuals. Dr. Wilson being a more conservative, staid person, Ron Baird being far more forward-thinking and a little more innovative.
Right. All these years in Toronto, was there ever any tug at your heart to go somewhere else? Or
There had been three, and each time I've looked seriously at another position. There have been other mitigating factors. The position just wasn't that much better, and balanced against my wife's career. She was a neurologist, and at one stage my daughter's very active dance career. And so, you know, I never quite saw a big enough motive to make a change.
Well, you had a package deal with your wife being a professional as well.
Exactly.
Yeah.
Exactly. And I think it's a little easier nowadays, but going back to the 80s, early 90s, that was not the easiest package to move.
Yeah. Probably it's not even appropriate to ask you why you stayed in academic medicine. You were really programmed all the way through to do that, weren't you?
Well, I think I'm probably hyperactive in a way that doing one activity for my whole career would not have been feasible.
And in your system, you can rise to the level of professor like you did, even ahead of being the chief of the whole organization like in Europe. And
yes, it's totally a separate mechanism. Our ranks go from lecturer to professor, and they're not tied necessarily to your academic contributions or commitments.
Did you have any visits to medical schools in the United States or abroad during this early period of time?
Not during my training and not during my very early stage. Probably one of the first visitations I did was when you and I met in England, when you were a welcome traveler, I believe, and I was a James IV traveler, and that gave me one of my first big opportunities to explore in detail other centers, and that was in the UK.
That's a wonderful program, and certainly a great honor for you to be a James IV traveling scholar. And
it was a superb opportunity. I feel badly that everybody doesn't have the opportunity to travel, or indeed don't make the opportunity to travel, because at about the 10-year mark in your career, when you begin to know everything and know how you can do it, is the time you need to start asking if there are better ways. And it was just an unbelievable opportunity. I don't think I've ever worked so hard in my life.
Well, and to see people like David Charlesworth whiz through an operation.
Yes, I think you and I were both embarrassed at how quickly he did an aortobifemoral with bilateral fem pops, with both of us getting in the way in the meantime.
No, that was a fantastic experience.
It was quite remarkable.
Who else during that trip did you meet in the UK with whom you've kept friendships?
The individuals that I've met were older, and so that's no longer possible. But it gave me the opportunity to, for example, visit one of the senior surgeons on his farm and learn that he was planning for his retirement with his wife in terms of planning to learn animal husbandry and actually doing it, to learning the different aspects of education and research. It was a great opportunity to reflect back on what I was doing clinically and in research. When you see somebody else do something that's less effective than the way you did it, is reassuring that you're doing something well, and of course it gives you the opportunity to learn new techniques. So it was a wonderful opportunity.
In your own institution, did you find challenges along the way in vascular surgery and identifying what you knew needed to be a new specialty? Were there people how about the cardiothoracic surgeons who had been doing all of the vascular surgery?
Well, I walked in the door and said I love doing amputations and seeing ischemic legs, and of course that's the one thing cardiac surgeons in those days didn't want to do. So it was actually a fairly easy job in my institution to get my foot in the door because I was well trained.
Right.
And so it was not all that hard to take over those cases, from whence the other cases follow. And there was no separate vascular division at that time. But very quickly, with the support of one of my mentors, vascular was separated off about 1978.
Yeah.
And it was from there that we had approval from the SVS committee, and then went on and formed the specialty at the Royal College.
And probably at that time the cardiologists had no interest, and the radiologists minimal interest.
None whatsoever.
We'll talk about both of those relationships a little bit as we go on. But have you been particularly satisfied with your academic side of your career?
I've been more than satisfied.
Yeah.
I've been very lucky. I've had the opportunity to work with collaborators who have taken science taken me along with them to science at really a very high level. So I've been delighted.
Well, you know, since we share the Society for Vascular Surgery, and I say it that way from the beginning, you and Ron Baird and others have made very important contributions. Why don't we have you just say a few things about when you were first aware of the Society for Vascular Surgery? How did you get involved?
I got involved through one of the very early meetings with Ron Baird. I believe I was a fellow. I can't remember even what city it was in, but it was as you know in those days, a small, very collegial society, and to have been included among a small group of physicians, surgeons, I thought was wonderful. And I can't say I made a commitment to continue my involvement at a high level, but as time evolved, I did, courtesy of Bob Rutherford, for example, who was one of the individuals I respect the most in North America for getting me involved.
Well, we know you were president of the Society for Vascular Surgery. What offices did you hold before being president?
I spent 25 years working on various committees. And that's probably the easiest way to summarize it. I was asked at one point by a couple of individuals who were somewhat impatient in moving their way up. I pointed out that I'd done my share of jobs over 25 years, and that's probably the easiest way to move your way along in any society or in any organization. So I've done things from the membership committee to other activities.
The companion organization was the North American chapter of the International Cardiovascular Society at one time, or Society for Cardiovascular Surgery. What do you think about the relationships during those years and the final 2003 decision to go together? Has it been a good move?
It's been the only move that was sensible. Going way back to a retreat, and I'm not sure what year, but it would have been perhaps 15 years earlier, to a retreat we had in the summer in one of the suburban hotels in Chicago. I remember chairing a breakout session with John Manning in it and Jim DeWeese in it, and talking about the concept of merger. I was an odd person out, shall we say, in that session. Andy Whittemore and I subsequently talked about it, and we both felt as that far back that this was the only way to go. When I was editor of the Journal of Vascular Surgery, I had a chance to attend some of the joint council meetings.
Right.
And I'd never seen quite such animosity in my life. I went in to give a nice report, and the fellows all had their jackets off and their ties loosened, and they seemed to be quite angry. I didn't seem to think this was the ideal way to run a society, and that would be the late 80s, I guess.
Yes.
So I felt for a very long time that it was the merger was necessary, and so that's why I was very grateful when Tom Riles and Jack Cronin pulled it together.
You've been kind enough to give us some of your thoughts documented from your presidential address, and you made a few predictions, if we will. Now a few more years have passed. Have you gone back to read what you were thinking might happen in vascular surgery, and do you think that has happened the way you envisioned it?
Our goal, the year I was president, it was about the 5th year of the society. Our goal at that time was to create a strategic plan. The first 4 or 5 years, we had to get the society joined. There were issues to solve. But by that point, we needed to have a map. And so Becky Marin, the executive committee, and the board had a retreat to develop a strategic plan. And the predictions, if you will, were global views on what might happen in the specialty, and therefore what strategic plan should be in place. So I think for the most part what we predicted came to pass. For example, There is a continuing increase in the prevalence of vascular disease because of aging, the obesity, diabetes epidemic. There's increased interest in minimally invasive surgery from the patients, from us. There have been major technical advances that we anticipated would occur, minimizing access to surgery. And indeed, we predicted economic change. We did not, I should point out, predict the 2008 crash, although it was in 2008. But we did predict the major changes that would occur in the economics and in the way that healthcare would have to be provided by different governments, obviously including the U.S. And that has absolutely come to pass with the prediction that the quality of care would be measured and would impact new models of how care is delivered. So I think of the predictions we had, perhaps not predictions, but bases for our strategic plan, I think indeed they were fairly solid.
At this point, we collectively have a message for Dr. Jimmy Yao, hoping that everything's going well in Chicago, and telling you, Jimmy, we're missing you. We're all having a great time. Peter Lawrence has just joined us. Roger Gregory is providing quality assurance for this interview. And we have Dr. K. Wayne Johnston pinned up against the wall to tell us about the differences between American, or U.S., I should say, and Canadian healthcare at this point, from your point of view, please.
That's a difficult question to answer. The reason I say that is because I come from a background of having comprehensive healthcare for all, and so to me, there is no other choice. What I've always seen in the healthcare system comparisons is the U.S. has the high of the highs and the low of the lows. We have in between and have taken off the low of the lows. I think that the problem we all face at the present time, and indeed the world faces, is none of us can afford the health care for everybody that we would want. Not possible. And so how do you set up a system that's going to balance that? And there are numerous models. Our model is very different. We have problems clearly in our system in terms of speed of delivery, wait times in some areas, and you have problems that you're well familiar with. So I don't think there's any ideal healthcare system.
No, each society has to decide how much they're willing to spend, and that is where the limitations are going to come in.
And most societies, at least governments, have decided that they can't afford anymore.
Let me turn it over to Dr. Peter Lawrence. Peter, what comes to mind?
Well, Wayne, first of all, it's a pleasure to see you, and congratulations. We've always known you're a great leader of not only international vascular surgery, but the Society for Vascular Surgery in the United States. So it's a pleasure to talk to you and interview you here today.
Thank you very much.
I guess one question would be to look at the contrasting of the two systems in vascular surgery, because you mentioned that there occasionally are delays in care in Canada, and yet my suspicion is that you may have had access to devices, particularly for vascular disease, as early as we did in the United States. As a vascular surgeon, what are the differences in practice? You've seen it on both sides of the border. What are the differences in vascular practice between Canada and the U.S.?
Remarkably few differences. You mentioned the availability of devices, and therein there is a very major difference. So we had access earlier, and indeed now because of our regulatory agencies, we actually have fairly straightforward access to new devices, more straightforward than you do. But the problem is paying for them. So in our healthcare system, the funding is all based on hospital funding. In other words, our hospital receives a package fund to run the hospital for the year, including the chemotherapy, the wages, and the devices. And so that within that, we don't have a lot of flexibility to purchase additional new devices that are going to come along because we haven't budgeted for them. We don't have that ability unless something else in the hospital is cut or unless money is reshuffled, and that's usually what happens. So we don't have a budget to allow us to purchase, or for the hospital to purchase as many devices as would be ideal.
Tell us a little bit also about your editorship of the JVS. What were some of the things that you attempted to do as that journal evolved, and what do you think are the contributions that you made specifically in that area?
First of all, I never intended to do that job. The announcement came out. I was doing what I had been doing, clinically, research and otherwise. And one night at dinner, totally out of the blue, Bob Rutherford called and said, I think we should put in an application for this job. I was totally stunned. I had never thought of doing this, and after thinking about it and speaking to some of my mentors at the time, we did agree to do that. So Bob and I went into this after we were accepted of a 51-49 deal. I was the editor-in-chief and therefore had the 51% vote, a vote that I knew, of course, would be hard to ever use, and indeed we never had to use it. And our challenge at that time was we were on the cusp of computerization. And so we went from a journal that was paper-based to one that was more computer-based. And that was the initial challenge that we had. And having succeeded at that, we then emphasized a variety of other things, such as ethics. We were one of the first to introduce conflict of interest. We were on the collaborative group that defined the statements that one should make when writing a paper with industry. Totally reasonable to do it, but the authors or the readers have the right to know what that relationship is, not just in terms of payment, but who analyzed the data, who had access to the data, and so on. So we did a couple of things, the computerization aspect, and secondly, some of the ethical aspects.
And my understanding is that I know that you extended your interest in the computerization of the JVS into helping and probably being the driving force behind the web-based, the website for the Journal of Vascular Surgery, or for the Society for Vascular Surgery, which you also did. Tell us a little bit about, was this a natural evolution from one to the other, or how did you get that job as the making technology come to the Society for
I think the
Vascular
day
Surgery?
after I finished doing the Journal of Vascular Surgery, I had a phone call because somebody knew I had nothing to do. Bill Pierce did a great job, as you may recall, of setting up the initial website. But computer technology had advanced very significantly and the society had not kept up with it. So our challenge was to develop a website, not the content, but to develop the mechanics of a website that would allow us to move forward. And at that time there were a variety of content management programs that were available that allowed you to take a document in a standard word processor format and put it into a website so that it would be linked, so the formats would be similar, it would be identical. And so that was the next thing we did, was put together a program that would allow us to automate entry of data. And it was from there that we then got the group together to populate the website, got the regional vascular societies on board for the most part.
One thing Jimmy wanted us to make sure we ask you, during your chief editorship, did you ever turn down a manuscript that you regretted later, seeing it in print and wondering why you turned it down? Did that ever happen to you?
As an editor, you try not to second guess yourself. I can't recall a specific paper that we turned down that I regretted, but I regretted turning down most papers that we rejected. Sure. Because it was a judgment call, and in making a subjective judgment call, you're wrong.
One of the reasons we were asked to ask you this was sort of two-pronged. The first being based on two well-known experiences when Juan Peroti's original work was turned down. And
not by us.
No, but Tom Fogarty's original effort with the balloon catheter also turned down. And one of the things Jimmy was asking at that point, does this mean that the editors aren't keeping up with the evolving changes going on in the specialty? And
that's always a risk. Some real innovations sound strange and sound impractical. We were involved very early in balloon angioplasty, and when I first thought of a technique of stretching an artery, because the mechanisms were not clear, of stretching an artery, breaking a plaque, and making flow improve, that really didn't make a lot of sense to me.
You know, we realized that you really were responsible in Canada for the vascular fellowship expansion and training and that type of thing.
Yes.
Tell us what differences exist in Canada and the United States today in vascular fellowship training.
Now very few.
Yeah.
We now have a primary entry program out of medical school, and we have the combination of general surgery and vascular for people who want to do it. So the programs now are totally in line.
You know, Dr. Jan Bruchenwald this morning told us in Germany now 75% of the medical students are women. And, you know, I don't know what's the percentage in Canada, over 50% probably.
Oh, it's over 50%. In Quebec, it's in the order of 75%. And we'll be following that trend, I have no doubt.
Well, you know, a young person approaching you, either man or woman, who asks you, what is the future in vascular surgery? How do you respond to that type of a question?
The future is bright. The opportunities now for training, be it in open, be it in endovascular, whether it's in diagnostic aspect, drug aspect, research, I think the integration of all of those is an exciting potential specialty. So it allows somebody to go into a field and not be wed to doing endovascular or open. They can do that, they can do medicine, they can do diagnostics.
And we're back to where we were when we first started talking. What about the competitiveness with interventional cardiology and interventional radiology? What is the status today in Toronto as an example?
Yes. I think if we take it even more broadly in Canada, cardiology is so busy doing cardiology that the cardiologists tend not to be involved with vascular care. And in addition, if you think about it, if you're in a system where the hospitals are funded globally for a budget and you're a cardiologist, why would the hospital tell you, why don't you just expand and do vascular as well? You know, you do cardiology. So there are very few opportunities for cardiologists to do vascular. When it comes to interventional radiology, it's quite variable across the country. Vascular surgeons, for the most part now, are doing the vascular interventions. In our center, it's actually a collaborative program. One of my colleagues, in fact, does full interventional call and is fully trained in intervention as a vascular surgeon. So he will do liver one day and vascular the next. So there are different models, but in terms of competition, I think vascular has won the day in terms of interventional procedures.
You mentioned one of the challenges was how contentious a time it was between two or several of the societies.
Yes.
And one of the issues there was the role of board certification and how independent vascular surgeons should be from the field of surgery or from other specialties that also take care of vascular disease. How's that handled in Canada, and where do you see the idea of board specialization going, both in the United States and in Canada? Are we going to become more independent or less independent as a specialty?
I'm not sure we need to become more independent. I mean, we control our own education in Canada and the United States. We can change our program in Canada by going through the Royal College, and we have an equal say. We have a total say about our program. Other programs can object to what we're going to change, but it's an open process whereby it's unlikely that if we proposed to change vascular training in a specific direction, it's unlikely if there was rationale in that there'd be objection from our Royal College. So I think, you know, we control our own specialty for the most part.
So right now you don't see a need for either in the United States or in Canada for vascular to become more independent because it's controlling its own destiny?
I don't think so.
You've read many, many manuscripts, as Norm pointed out, some of which you've not accepted, but many of which you have. So you probably have seen the real spectrum of work that's being done. Is there any area that's comparable to the endovascular revolution that you can see coming in vascular surgery? In other words, where 5, 10, 15 years might we be as far as some technology that will dramatically change our specialty? Did you see anything coming along as you're looking at all the manuscripts and all the great ideas for technology?
Remember, that was past tense when I looked at the manuscripts, so now I get to read what have been filtered. So I'm not sure that I can answer that question very well. I mean, I think there's two areas that are going to have major technical changes, and I believe still the miniaturization and the imaging related to treating vascular disease. I think there's still the opportunity for significant improvement, and that's going to impact vascular in terms of patients we do, accessibility to disease. The other area, which I can't predict, nobody can, is going to be drug treatment. I mean, you know, when's the next blockbuster drug going to come along that's going to have a major impact on our specialty, or when is something going to come along that's going to allow us, not perhaps a version of gene therapy, to allow us to treat vascular disease in a different way. I think one of those or both those will happen in the future. When, of course, don't know.
It seems like restenosis is a universal issue
Yes.
for occlusive disease.
Yes.
Did you come across any sort of promising approaches to restenosis, or is that still one of the
I think
major
it's one of
challenges?
our major challenges. It's been with us all of our surgical lives, and lots of options have been exhausted without success so far. In fact, I have a difficult patient right now. I'd be happy to share if somebody has some new treatment that's available for restenosis.
With the endovascular revolution, one of the great concerns among vascular surgeons is that the amount, the volume, and the complexity of open surgery has changed. It's changed throughout the world, I understand, but probably as much in Canada as it has in the United States. But what do you see as solutions? Is that as simulation, as regionalization? What are we going to do to maintain our open skills as an increasing percentage of patients have these miniaturized, minimally invasive procedures and aren't candidates for open procedures?
I think what you mentioned is the way to go. I think there will be increased specialization and therefore regionalization in at least the more difficult open techniques. I would like to think that the vascular surgeons in the future will still be trained in the standard open procedures, but the more difficult ones, be it a redo carotid, a juxtarenal aorta that needs to be done, I think they'll be done by individuals who have advanced training, and so I think it'll be regionalized. Secondly is that there will be individuals who will be doing fellowships in open surgery.
And is that possible in the Canadian
Not
system?
yet. Not yet.
With hospitals controlling budgets, will there be is there a mechanism for regionalization?
The short answer is no, but our province, as one example, is looking at how to restructure vascular services. I was involved last year with a group at the request of the Ministry of Health to put together a strategic plan for vascular services in the province, and realize that's more than vascular surgery. And one of the aspects of that is regionalization of how you deal with that effectively. And so the hospitals, the government, then the hospitals are going to have to come to grips, I think, with regionalization of advanced vascular cases.
You mentioned your relationship with Bob Rutherford, and of course your years on the Journal of Vascular Surgery with him. It must be an exciting opportunity to work with Jack Cronenwet on the Rutherford textbook of vascular surgery. Tell us a little bit about that.
Jack and I, Bob Rutherford, I think, wanted Jack and I to succeed him. Elsevier, I believe, wanted us to succeed him. And at that point, the Society for Vascular Surgery realized, while I was in the region of the executive committee but not involved, that this would be a nice activity to have under their control. And so it took some time before we actually got to be appointed as editors, because the negotiations with Elsevier and the Society for Vascular Surgery took a while to sort out, because it is a fairly unique arrangement whereby the society signs the agreement with Elsevier and not the editors, and then we're appointed by the SVS. So it was a little longer coming than either Jack or I thought, and then we realized that we had to do it because of our huge respect for Bob Rutherford, and that's the reason we did it the first time, and we've agreed to do it a second time. Second and last time, I should
Just
say.
to show you Bob Rutherford's outreach, vascular trauma now has followed the same path, because Bob Rutherford said to me, why don't you use the Rutherford approach that we have Wayne Johnston and Jack Cronenwet doing. So we do have that for vascular trauma through the SVS now. So
well, that's
it's
interesting.
Very interesting experiences.
Yes.
You've finished 8 editions. Are you working on the 9th?
No, we're working on the 8th edition.
8th edition,
yes.
okay.
Yes.
Good. Well,
more difficult, I discovered, than the 7th. The 7th we started with almost a blank piece of paper, because we were at the upswing of the knowledge on endovascular. So the previous edition was just as endovascular was evolving. We knew it was coming, but there wasn't solid data to put in an encyclopedia. But the last edition there was. So we discovered we had a lot more work last time, as did the authors, than we'd anticipated.
When you've had so many different things to do, journals to edit, textbooks to edit, a practice, the politics and the involvement with the SVS, when you begin to slow down and look at retirement, I'm sure you're busy now, but what do you do with your time? What sort of activities give you the same enthusiasm and passion that you had when you were practicing vascular surgery?
Well, I've discovered now that because I stopped operating about 4 years ago, I've discovered that you know, other activities do fill your time. You don't have perhaps quite the same, at least I don't have quite the same passion to work quite as hard as I once have, and I think as a result what I do now, I do in a little bit more detail than I may once have done, and appreciate it a little more. So, you know, I have other activities, gardening and photography being the main ones.
I think I've talked to you on the phone when you were just in your garden, so that takes a significant amount of your interest and time.
Well, it does, 6 months of our year, yes. We're fortunate. We bought a property in the city a long time ago that's an acre. And so there's enough soil there to till and enough plants and bushes to prune. So in the summertime, that's good fun. In the wintertime, it's more of a challenge, but photography and other activities keep me busy.
Again, you're so organized. We've been through this so fast. Is there anything that we've left out that you would like to include from all of your documentation that you have about your career? Is there anything that we've kind of overlooked? Let's look at some of your clinical research. How about ultrasound? You had a long interest in that, and you were one of the first people in Canada to be interested in ultrasound. Was that, again, some of the mechanical, biomechanical interest coming through?
My areas of research and interest have been basically ultrasound and hemodynamics, and the hemodynamics came out of an interest in ultrasound. So very early on, I recognized the limitations of vascular laboratory assessment, because in the early 70s it was fairly crude. And we realized the value of an ultrasound probe. At that time, there was no good method clinically to evaluate somebody in real time. So we were one of the first to develop and apply in a routine way real-time frequency analysis to routine vascular lab use. So that's sort of one of the things we did early on. And from that, we then developed our integrated engineering program related to further improvements, much of which relate to engineering developments as opposed to clinical developments. But we were very early on in the evaluation of techniques, the evaluation of human factors, and so on. And it was from that, the ultrasound, that we developed an interest in hemodynamics, and I developed a technique that we'd heard of visualizing flow in a tube, not in an animal, that allowed us to critically look at what flow patterns were. And of course that is very germane to what you record with ultrasound. Right. So we were able to record flow patterns, complex flow patterns in pulsatile flow in the region of stenosis and anastomosis and so on. So that gave us insights into ultrasound and what it could do. It gave us other insights into poststenotic dilatation, vena cava filters, and so on.
You mentioned you haven't had quite the European exchange that you would have liked to have had. I can envision, just talking to you here today, how exciting it would be for you to walk the footsteps of Christian Doppler, starting in Prague and going through the various locations he was, and with your, again, mathematical interests and everything, as a mathematician as he was, studying astronomy when he made his first observation. Yes. I've tried to understand that. I've never been able to really understand his observation. And of course, as you probably know, most people thought he was crazy in that period of 1842 or whatever it was. But please.
Well, and that's the problem of a journal editor, is you have somebody who is very forward thinking, and of course their thoughts appear. You can't tell if they're innovative or schizophrenic.
Right. Have you ever had any interest in Christian Doppler as a person, or have you?
No, I haven't. My longtime collaborator Richard Cobbold has, and he has walked those footsteps.
Ah, very good. Okay, well, fantastic. Hemodynamics. Expand a little bit on that for us, please.
Well, as I mentioned, our interest came out of trying to understand what one could record with ultrasound, and from that we noticed that there were abnormal flow patterns. So for example, after a narrowing, there are flow patterns of recirculation of flow, and there's actually a pulsatile, oscillatory I should say, low shear rate. And the question is, why do you get a post-stenotic dilatation in that case? And it's almost certainly related to what signaling occurs between the endothelial cells, which are subject to a very low oscillatory shear, and nitric oxide. The original experiments by Cushing, showed that you made a narrowing, the vessel dilated, post-stenotic dilatation, you take it out, and the artery goes back to normal. Well, that's clearly a biochemically mediated event, which occurs because of a hemodynamic factor. So that was an area of interest of ours. The atherosclerosis, of course, was an interest. Aneurysms were as well. And one of my collaborators has continued actually to do work on vena cava filters as to why some filters do not perform well clinically, and it's probably a hemodynamic basis.
Was there ever a particular procedure that you like to do more than others, open or endovascular?
My partners at one stage defined me as the person who did things in centimeters versus them doing them in millimeters. So it was the aorta, and I did a lot of aortic aneurysm work, especially juxtarenal aortic aneurysm work.
I think one good question too is, do we have too many societies in vascular surgery?
I don't think so. I think the SVS has risen to be the voice for vascular surgery, and I think that is the key thing. We need to speak with one voice. The regional societies need to hopefully apply that voice regionally and to provide the regional education. I mean, the key component here is, I think, education when it comes to the regional.
On behalf of the Society for Vascular Surgery, Dr. Johnston, we thank you very much for this interview. It's been spirited. You've given us a lot of good information. Thank you very much.
Thank you for having me.
And also, Wayne, thanks for the contributions you made to the American vascular scene, because when you think about it, there have only been 2 or 3 Canadian surgeons who have not only held leadership roles within their own countries, surgical and vascular community, but also the United States, and you've really been a role model for people coming along as to how you can do both.
Thank you. Thanks, Pete.